this is Renato Suntay. I'm the Chief Financial Officer for Meadville Medical Center, and we're located in Northwest Pennsylvania, which again is sort of more under rural setting compared to Pittsburgh, Erie, or some of the other bigger cities in Pennsylvania. I have a 2-hospital system with several, well, actually more than several rural health centers, and we are definitely considered a rural hospital. But from a regulatory standpoint, we are a sole community hospital, and the other hospital that I have is a critical access facility. So again, we go by 2 different reimbursement rules, and it helps us really in terms of how we try to balance the services and really the care that we're delivering here in the county. We are the only provider, the only 2 hospitals within Crawford County, Pennsylvania, and the nearest facility that other people can go to is actually about 40 miles away, which is in Erie, Pennsylvania, or further south to Pittsburgh. So that's where we're located at, and that's the operation that we have.
Very interesting. So, well, welcome. Thanks for being here. Tell us a little more about what it means to be a rural provider as opposed to, a city-based provider, like you said.
A rural hospital pretty much has a little different mix in terms of the types of services that we perform. We can't be really a tertiary care facility. We work closely with other tertiary care facilities, wherein we refer patients that we can't handle over to them as quickly as we can. But within our community, it is our goal and the board's mission statement to try to really maintain a lot of the services here locally as much as we can, based on the capabilities that we have, and really try to maintain and keep the service local for people so they don't have to commute to more distant places in terms of trying to get the care. So as much as possible, we try to bring our own specialists in. We do hire them. We do have our own equipment and everything else, to the point that we do have a separate cancer center that's doing very well, and our own outpatient surgical center that does a lot of really good procedures for the community.
Fantastic.
So overall, I think we're doing fairly well. We've been able to continue to provide the services without having to look at other organizations to work with. We have closely aligned referral systems for the needed care that we have to give above and beyond our capabilities. And it's worked well for the community and us. So the hospital has remained profitable, and we try to make sure that we can continue to provide the types of community services that are needed here in our community at a reasonable cost.
Well, it's very important, access to care, and of course, keeping it affordable. And of course, no conversation about healthcare is complete without touching on the pandemic. Of course, you've had some challenges with that, I'm sure. Can you tell us what you've been dealing with within your system?
Yep, that's pretty. That is a good point, Igor. Based on what we've got, we are seeing a slight increase right now. Initially, when the pandemic started, we had some very large number of cases that have been coming in. And definitely we had to scramble ourselves because we really didn't understand what this pandemic was all about. As we learned things going through the different readings that we've had and basically communications with the health departments, we had to really strap up quickly and equip our hospital with negative pressure rooms as fast as we could. So as these patients are coming in, all the ICU beds that we've got, and we've got a dedicated COVID floor where we have the ability basically to turn on the switch and put negative pressure rooms and care for these patients as needed. We had to get familiar with the new treatments that are being given to them with regards to the medications and the different monoclonal type care that's being served by some of the hospitals. And again, had our network set up quickly to be able to have direct communication with the Department of Health and other or larger facilities to be able to pick up the techniques and necessary pieces of technology to be able to combat this. So overall, I think we've performed very well. We've had very minor complications that are occurring. We do have some deaths, as always, but again, it's because of the complications and the comorbidities that the patients had. But as we actually went through this pandemic, though, we've been able to control really a lot of the spread of this disease. And we actually had pods that we set up. Once the vaccine was available, we made it available to all, basically, our community members, and had a very large group of employees that actually gave the vaccines at one of the large centers that we have here, which I had to lease to make sure that people would come in, get their vaccines, give them their card, and then get set up for the second vaccination that was necessary after several weeks. So I think we've done fairly well. The community responded very well. And to this point, we're just managing it as it comes in. The majority of the COVID patients that we have now are mostly the unvaccinated people. And that's who we're trying to care for and really giving them the proper treatment so they can be able to get home.
Understood. So it sounds like you had to scramble and move quickly when it started to happen. How far ahead did you know how much work had to be done to make that possible? How many changes did you have to do to the hospital system itself? And from a financial standpoint, what kind of investments did you have to make? And were you able to spare the funds? Did you have the funds available? I'm curious what your lens, especially being finance, what your view into that was.
Right. Well, what we did was we do have capital funds that we had available. But what we had to do, unfortunately, was to divert these funds for the specified use and actually purchase additional equipment like respiratory type machines, the negative pressure machines that we needed to put in the rooms, and really the PPEs that we had to make sure that we had available for basically our staff and the workers of the hospital and the physicians. So we actually reallocated a lot of the capital funds that we've got for this purpose.
Understood. So since we're talking about finance and we're talking about capital funding and equipment, of course, equipment plays a huge role in healthcare, especially these days. A lot of innovation is happening. And of course, patients demand access to the latest equipment. They want the best quality of care. Curious about what your thoughts are on some of the challenges in that space. Investing into new technology obviously comes with a price tag. How do you balance those needs versus your operational requirements?
Right. Well, on our part, basically, we do have an annual budget that we prepare for capital. And we do have a specified list of capital projects that we are funding. So what we do well ahead of time is decide how we want to really fund these capital purchases. So there are several ways that we do that. One, we take it out of basically our operating funds if needed. Two, we go with either a bank loan, and mostly what we do is we try to syndicate that amongst different banks, basically, and have a pool of money that we apply for, and they actually fund that for us. And the third way of doing that is either doing a bond issue, basically. So we did a huge bond issue back in 2016, if I'm not mistaken. And then really from that point forward, though, we've been really working with just our own operating funds to capitalize it. We do have some capital funds that we have available, which is coming from our depreciation fund. And we actually augment that with borrowings basically from some of the regional banks that we've got. Mm-hmm. So normally what we do is we package this whole thing. We come up with a $10 million loan package. And then we actually request banks to provide what is the amount that they want to fund for us, and then we syndicate the whole thing. So basically, we usually work with about 3 or 4 different banks to generate the capital fund that we need, and then actually do the purchasing. This year, we're going to have some major pieces that we're looking at. One is the construction of a new radiation oncology vault. which is really going to be for a linear accelerator. And then I got to buy the new linear accelerator itself, which is a fairly large ticket item. So right off the top, for these two big items, we're already investing close to $5 million just to be able to provide the services that is needed. And fortunately on our part, it is a department that has done very well. We do have a lot of people being referred over to us from, I'd say about 96 different zip codes around the area here. And we've done fairly well. So that's the reason why we need some new equipment, because the one we have is fairly old, and we want to make sure we have the best possible technology available for the patients that we've got. So capital is an ongoing need that we have here for the organization. The other big piece that we have is really the operating rooms. We got to make sure that we have up-to-date instrumentation, scopes, and the different cameras and technology to be able to provide the services for the community. And the other large area that I have problems with is radiation, basically the radiology department. Radiology is one of the highest cost toys that we have available here at the hospital, between the MRI, between the CAT scans, and all the regular X-ray rooms. Those always have to be updated completely. And on top of that, now that everything is digitized, we need to have a substantial amount of storage space to be able to archive these films and shots completely. So that's where we spend the majority of our capital, really, in terms of keeping up with the different technology spaces that we have. One of the largest piece nowadays, though, has to do with really cybersecurity. That never was a problem for us before, but with all the different hackings that are going on and ransomware that's been occurring really within the hospital healthcare organizations, we have had to beef up really the way we actually secure our information, secure our data, and actually add additional security so we can't be penetrated from the outside with regards to especially the medical records that we've got here at the hospital. So that has been an added additional capital cost for us, and a little more operating cost because we try to monitor this in a 24/7 basis.
Mm-hmm. Yeah, cybersecurity, of course, is a constant challenge, and and that's my sweet spot. Of course, that's where I can add a little more value to this conversation. Having spent 20 plus years in cybersecurity, and of course, dealing with things like ransomware is never easy, and especially when it has to do with PHI and also affecting not just the data, but also your ability to deliver care in the first place. We've heard about that major compromise that happened not that long ago, where cancer patients were actually turned away from their treatment because the records weren't there. They couldn't dose them properly, and the records weren't there because they were locked up by a ransomware attack. And so when you actually have lives at stake, it stops being sort of this hypothetical, technology only problem, and it really starts affecting not only just patient care, but also ability to deliver any care at all. It's not about quality. It's not about a feeling of security. It becomes very real and it becomes very tangible. And of course, regulators are also paying attention. We saw, this is outside of just the medical space, but the SEC recently released some information about, I think it was more of a leak, but they're talking about personal liability for directors. So kind of a Sarbanes-Oxley analog to in a cyberspace. And so a lot of firms have gotten requests for information about past breaches. They had to do with the SolarWinds attack. And now there's a question in the industry, are we going to get to that same level of liability, personal accountability for executives if they haven't done enough to combat cybersecurity threats? So that's obviously that's the emerging trends that we're seeing from our end, from the cybersecurity space, but of course in the healthcare space, which occupies such a huge portion of our economy, and of course affects so many people daily, especially with the pandemic. People are very concerned about it, and I think regulators are also starting to pay a lot more attention to it. So you're investing in it, and that's great to hear. And of course, a lot of the questions aren't, can you stop it from happening? A lot of times we're not able to, but how quickly can you recover? Can you minimize that damage? Can you mitigate the threat to a degree possible? And also finding out what your risk appetite might be. And of course, knowing how much is at stake is your stakes are the highest there are. You're not running a gas station. Somebody can't get their gas, it's a problem. Somebody can't get their cancer care, that's a much bigger problem. So I sympathize with the challenges that you have.
Yeah, no, I agree completely, because these things are very complicated. Once they lock you out of your medical record system, it is very difficult to treat patients because you don't have prior history. You don't know what the dosages are. You have no idea at all how to treat these patients. And it gets to be a very important decision to make whether you're going to release that ransomware or pay up that ransomware cost or try to restore everything or rebuild everything. Because again, unless you get that key, they're not going to let the information come out at all. And it's going to be very difficult to do that. So part of what we've got is basically the fact that we've outsourced. We put a lot of our hospital systems on the cloud nowadays, which assists us in terms of really monitoring the security of our information. But at the same time, though, it doesn't protect you completely. But it's a little bit better that we can actually restore that and reconstruct it rather quickly because of the fact that they do have 2 or 3 different backup sites that we can count on compared to just being a local store it yourself type system that we have here. So that did cause problems.
Yeah, naturally. Well, and the pace of innovation also, we talked about innovation, we talked about equipment and making sure you're investing in the right technology. I'm curious what you've seen as a trend over the past maybe 24 to 48 months. Has there been an increased pace of innovation, adoption of technology into the healthcare system, especially within your hospital system? Of course, the pandemic, you had specific changes that you had to make in order to combat COVID. You talked about negative pressure machines and things like that, but also the necessity of moving data around quickly and absorbing data quickly and dealing with a larger set of patients potentially on very specific issues. Have you seen a quicker rate of adoption within the healthcare space? We always hear about, 10 years ago, hospitals were running on paper and now everybody's in the cloud. Has that been a bit of a whiplash? And also from a financial standpoint, how do you predict something like that? A trend that just accelerates so quickly. How do you fund that? Of course, you talked about some of the ways, but do you have like an emergency technology fund that you can, fund things in the next 18, 24 months if you have to?
Well, that's part of the strategic approach that we take when we develop our capital fund. We do have what we call the planned capital fund that we have, but we have what we call also an emergency fund that we have set aside for anything like this that may occur, where we may need some additional capital funds to be able to secure a lot of things or purchase additional equipment that pretty much has a tendency to break down that you weren't aware of. So this emergency fund that we have really has been utilized a lot, especially in the cyberspace, because we've had to really beef up really the development and implementation of new security systems that we needed in place here for the hospital. So I agree with you completely, though. I've used third-party companies to come in and really assist us with that. And so far, they've done a very good job. We try to train everyone as to how these types of viruses are spread via email testing. We continue to educate our users, really. And sometimes it gets very difficult because I've got 1,700 employees here, and majority of them, 90% of them, have computers. And once they get into their emails and they don't recognize really a cyber issue, really without a good IP address, then you're vulnerable that they can open it up and then you could be in trouble again. So we try to minimize this as much as we can, trying to pick it up front, freeze that at that point, or at the same time, educate every single one of the users that we have. And that's tough. That is difficult. You've got a lot of bodies that you got to train. And one person opens something up, you never can tell what's going to happen. That thing can spread like crazy.
Right. And that's the challenge, right? One link in the chain can be the weak one, and then it breaks the whole thing. And that's the problem. So you try to minimize it, try to put all the controls in place. And of course, you have to constantly invest into that. And
exactly.
There is a challenge there. A lot of these things are very thirsty when it comes to funding, and you do have to pay the ongoing maintenance fees. And I'm sure that's the same way with medical equipment. You don't just buy it one time, right?
No, you don't.
And there's training, and there's upgrades, and so that's certainly, the pace is a lot quicker, of course, in the cybersecurity world, but certainly we're both not immune to that. You never make just one capital purchase. Just there's ongoing.
Exactly. And again, we make the determination whether it's going to be an operating expense or a capital expense. because sometimes the ongoing expense is definitely is going to be an operating expense from that point forward, and you got to maintain it really. So again, that's part of what you have to do, and it changes your cost base completely.
Mm-hmm. And we're talking about cost now, right? So let's talk about that. So you talked about quality of care. Of course, that's an important concern. You're delivering good care, but also you have to make financial decisions around that. You know, how much is too much quality? You know, you have to strike that balance between cost
Right.
and effect on target. So maybe you can talk about that and share with us your vision and how you deal with making those decisions.
Well, in terms of looking at what we do, again, a lot of these new programs that are in place with regards to quality measurements and reimbursements are fairly new, because people are experimenting with this to find out what is the best blend or what is the best way to try to reduce cost and increase the outcome, better outcomes for the patients. Well, unfortunately, a couple of things are out there, though. I know the ACOs is a great example, the Affordable Care Organizations. Yeah, their biggest push really is to see if you can actually have better quality results, lower readmissions, better outcomes from the treatment that you're getting. And they look at specific DRGs or illnesses and everything to see if they can measure it properly. To come up with the results that they're looking at. Well, what they've done is actually base everything on overall reimbursements from, let's say, Medicare. And with that, though, the way that they manage this is the lower basically your length of stay, or the lower the cost of referring patients to, let's say, a nursing home or a home health agency and things like that. That's how they measure the cost of care that's being delivered to the patient by that DRG or whatever they call that. Now, the problem is, though, is when you measure the results, they're not always equal. The results are very, very hard to measure. And whether this patient got better or not by the way we handled that or referred the patient out, a lot of times it's very difficult to pinpoint that was the reason for that reduction in cost. But the majority of the cost reductions are just using different types of care deliveries that cost a little bit less. But did the patient get better? Well, they were discharged to home. Does that mean they're better? Not really, though, because a lot of times you still have home health keep coming in and start really delivering additional care for those patients. Mm-hmm. So my concern there is the fact that, again, as you reduce your costs, they have what they call basically cost sharing. Mm-hmm. If you reduce the cost, you share the reduction with the government. They get 50% of whatever that is. They keep the money for that. And then 50% goes to the ACO, of which they distribute that based on the number of people you have enrolled in that ACO. So the quality dollars that you're getting above and beyond that, though, is sometimes very questionable. From my standpoint, I had to add 3 more staff. I have a population health management group now that has nurses, that has social workers, that has LPNs, and so on down the line. And I pay a fee to the ACO to use their systems and help them manage basically our organizational utilization of patient services and resources. And the overall number is not turning out to be really positive, though. The results, I'm behind in terms of what they say the quality metrics are. We're not up to that par level yet. The cost is substantial in our organization because we're monitoring all of this, and it's all the bodies that I had to hire to be able to just work with these organizations or the ACOs that we have. So I have not seen a benefit yet for our organization in terms of really the dollars that we're spending and the overall quality of the patients, because again, we're still seeing the same patients that are coming in here. We could have done this on our own without having so much overhead. And is it really worth really moving into this type of arrangement? 2 things I know of that benefit from this is basically the ACO and the government. That's pretty much it. our organization hasn't seen any benefits yet. Cost-wise, it's still costing me money. I'll be honest, it's costing us close to $1 million to operate this thing. And from a quality standpoint, I have not seen that bar go up yet after 2 years. So I think it's something that makes you wonder, is it really worth it? Or is there a better way of doing this without having all these other expenditures or really directly managing it on your own instead of going through a different organization like an ACO to accomplish what we're after? I think there's actually a better way of going about this in terms of really making our people work closely with our patients and not have that additional cost that we have to pay through the required reporting and required staffing that we're being called for by the ACOs. So I think that's something that, again, it makes your organization feel good that you're doing it, but the hospital basically still does not have the financial benefit of it. And I still have to question the quality improvement because I have not seen movements in that either. Mm-hmm. So I think that's part of, right now, that's part of what we have to look at as financial people within the organization. Is it really going to be something worth our while to pursue this? Or are we better off looking at other ways and other resources of being able to manage this properly and see some benefits out of what we're investing in? I think that's the question that I have. From a quantitative standpoint, I know it's not working. From a qualitative standpoint, is it really working in terms of the quality bars that we got set up? Is it really improving the patient delivery? Is it really bettering the health of the patient? But everything is based on the ACO's way of measuring those quality numbers. And unfortunately, the bar hasn't really gone up. And that makes me question, why are we doing it then at that point? Mm-hmm. So I think these are things that, again, you just have to think through. I may have to put a team of really nurses and physicians together to see if all the hours that we're spending on this is really benefiting the patient. And is there a better way to develop a different type of program and achieve it at the same time at a much lower cost? Yeah, I'm willing to spend money on and lose money on programs like this, but you want to have some good quantitative results that are showing you that it is doing something better and it is improving the delivery of care that you have. So given that, that's the only reason I have concerns about what we're doing and how we're accomplishing it.
Well, that's clear, and I appreciate you sharing that view. All right. Well, look, a couple of things that drive me is incentives create outcomes, right? And it's an operative phrase that I use all the time. And it sounds like some of the incentives that are being set up here may not be set up with the patient's care in mind or the patient outcomes in mind. Ostensibly, they are, but what you're seeing on the ground, what you're actually experiencing, is not necessarily the case. And another thing is, you measure what you know sometimes. And I'm fond of this old story of a man looking for his car keys, and he's under a street light, and another man comes by and says, "What are you doing?" He says, "I'm looking for my car keys." He says, "Where'd you lose them?" He goes, "Over there in the ditch." He goes, "Well, why are you looking here?" He says, "Because the light is better here." Right? Light is better here. And sometimes that's your view, right? Now, if your lens is that, and the outcomes you're trying to drive are maybe personally motivated, and sometimes that bias is not even clear. We set up some of these things, and the cognitive bias can creep in, and it affects everyone. The scientists, data analysts, investigators, in the medical sense and in the criminal sense. You get that myopia built right in, and you're not looking at the whole picture. And I think, to your point, is it's important to not only measure the instance, but also measure the entire holistic experience.
It's the holistic piece that you got to look at, because a great example, like you said, though. I know one of the things that my team of population health nurses does is try to make sure that they meet their annual examination, basically, for certain services that they've got. Well, the revenue is showing up in my physician practices, but since it's the population health people that are doing the work, do I allocate that cost over to the practice and basically give me a better idea of how much we're really losing in that practice? Or do we still keep it separate? So what I've done is I looked at the overall picture of the whole practice plus population health And I'm back to questioning, again, the results of what we're doing, because the overall number is still showing me a negative number, well, no matter where I place it. So again, there has to be a better way of doing this. And the more you partition things, the more you're going to lose sight of what that big picture is going to be. So that's the reason why I'm trying to get everybody to combine it all into one big place. And then let's see what we're doing here overall.
Mm-hmm. Well, you start slicing data thin enough, and then you get to these small, tiny little chunks, and within that one space, it might look fine. But like you said, holistically, you got to look at the entire picture, and then you got to understand, again, what's the focus? What's the pivot point? Is it the patient care? Is it the patient outcome? And can you look at it in toto for the entire life cycle? And then, of course, do you have the ability within your data analytics model and your platform even, because sometimes these platforms, I mean, look, you have to keep data for 7, 10, 15, 20 years, right?
Right.
But keeping it versus keeping it available for analysis, actually making sure those data sets are included in your analysis picture, where you can actually track that patient for their entire life cycle.
For entire life cycle, correct.
Right? That's very difficult, and especially as data points become a lot more convoluted and we have a lot more data. With things like, everything is instrumented, everything's got an IP address in the hospital now, from the infusion machines to even, I mean, I've seen it myself going into a medical care facility where some of them have built-in Wi-Fi in their blood pressure cuffs, right? And it just shoots right to your patient chart. And some of them, they have to type them in. And I always wonder about the quality of data, because every time you put a human in the loop, you incur potential error rates. And so I always wonder who made that decision, how that decision got made, right? But to the point, the larger point is everything's data is everywhere. Every piece of device that you've got out in the hospital is shooting something about that patient or the environmental data to you. What do you collect it? Where do you keep it? Of course, the cloud, yes, but there are costs there. And of course, you're being metered by use. So it's a lot harder sometimes to justify, well, let's just keep everything in the cloud because we want to get access to it. Now, the insurance companies are certainly doing it. And so
they are, definitely they are.
And, I talk to a lot of folks who are in that space, purely from a data science perspective. And the amounts of data are staggering. I mean, petabytes and petabytes of data that they're collecting on a daily basis. And they're using data lakes, and you're doing Hadoop clusters, and they're using all this kind of fancy technology out there to figure out, and they're training machine learning models that are servicing certain patterns that they didn't know even existed. Right. And so they're overlaying, healthcare fraud data with healthcare quality data and patient outcomes data. And they can do all of that basically from the same interface. It's incredibly powerful. But then I think also, when you look at a smaller healthcare system, it puts you on unfair footing. You're not on par. You don't have that same analytic capability. So you almost start dealing with asymmetric capability situation where, they might tell you something about your patient care. And they might say, we're seeing these outcomes and you should not render care at that quality level. We want you to go lower or higher. And you don't have anything to say back because you don't own that data to that level of detail, right? Correct. Do you think, is there a concern there? And are you investing into analytics as a result?
Yeah, well, that's part of what we're looking at right now, though. I am investing in analytics because, again, it is an unfair model that they have. They can see everything that's going on for one patient. I have just a piece of it. So again, that rolls into also really your negotiation with them in terms of reimbursements, because that is a key information you need to have, whether you can actually control your cost or if it's something that you really need a higher reimbursement for the type of care that you're delivering. And that makes it very difficult a lot of times, because again, these guys know exactly what's happening to that patient, and you only have a small piece of that information. And you're still trying to catch from behind, and all of a sudden, though, you're not getting reimbursed the proper amounts, and they're the ones keeping all the profit, basically. So I think you're exactly right, though. But one of the things that hospitals really need is the analytics department, but we don't have the kind of powerful tools that they've got, and I don't have enough funds to staff a good analytical department compared to what they have. So I think we're always going to be behind the 8 ball. We need to use basically our judgment as to what we've got in overall cost per individual care and try to work out really a good reimbursement scheme with them to be able to at least be able to keep your doors open and keep it moving. So I agree with you completely, though. It's a lot different nowadays. Even before, when we negotiated rates for these guys, it is a totally different picture nowadays because they know exactly what your markups are going to be, what type of drugs you're using, what the cost is going to be because they got the PBM contracts and everything. And they understand completely what makes up your structure. So they always have the upper hand when it comes to negotiations, really.
They have the data, they have the picture, and then, like you said, you only have a slice of it. I mean, I think there's a word for it in Hungarian. It's called salami tactics, right? You kind of divide. It's the classic divide and conquer, right? There's
Exactly.
one giant insurer. They have all the tools, and they've got all the data they've collected from everyone. And on the one hand, yes, it enables them to make these big decisions and look at trends at a large scale. But then here you are trying to get a reimbursement, trying to go to battle against some finding or some kind of determination, and you just don't have the data. Now, potentially somebody else has that data, right?
True.
Who saw that patient last year, potentially, right? But how do you get, you might see that patient chart, but how do you extract that data knowledge that you need?
And that's the hard part, though, is that even if they're referred to you from another place, you still don't have the ability to gather all that information so you can analyze it properly. Mm-hmm. So I think if you have something to deal with in terms of some of these patient data, the points that we have, the very limited data we have is going to be basically substantially less than what these insurance companies have really on you. And all you can do is really try to negotiate everything properly, look at your overall cost, and come up with a margin that you think that you'll be able to live with to keep your doors open. So it is very difficult, though. It's something that, again, in accounting, basically here in the healthcare field, you don't have a really good cost accounting system either because it hasn't been developed. You've got too many bits and pieces of supply lines or medical necessity supplies that sometimes you don't even know of that's actually being utilized in there. Mm-hmm. So again, these are things that you're just going to have to look at from an overall standpoint and really come up with a good estimate as to what that cost is going to be.
Very challenging. It almost sounds like you guys could use some kind of a data sharing consortium between providers. Oh, yeah. That parallels sort of what the insurance company has and or have, and really enable you to create those data use cases for yourselves so that you are on that same footing with them, or at least approaching that level of capability. Because right now, it's guerrilla warfare against the most powerful military, basically, is what you're looking at.
And they got the money to be able to invest in all the equipment and the analytics that's necessary. So unfortunately, there used to be the HIE, the Health Information Exchange, that people were developing for hospitals to be able to utilize, but that has gone by the wayside, though. I'm not exactly sure why that was not pursued to the deepest degrees possible. We were starting on one, then all of a sudden it just fell apart. So I have no idea what's been going on with that. So now we're back to looking at our own information, getting all of my patient bills and financial information necessary with the proper diagnosis, and then making our own conclusions based on what we have here, really.
You almost have to ask the people that you are, I mean, basically you're asking other people for your own data, right?
Exactly. I need the help of, let's say, a United Healthcare or Aetna to share their information they have so I can analyze my patient information.
And of course, they're not interested in that.
They're not going to give you that.
You're opposed. You have opposite sets of incentives. Yeah.
Yeah, they're not going to help you out, so they'll have to pay you more.
Right. Yeah, they're not incentivized to do that. No doubt. No doubt. Well, a lot of challenges, of course, and I'm really glad that you joined us here for this podcast. Fascinating world you live in, of course, and stakes couldn't be higher. It's human lives and human health, and folks are really paying attention to this now, especially with the pandemic. Maybe some people didn't consider their health as much of a priority, but certainly it's come to the forefront. And your view is financial, but yet it's so important, so critical. People think of hospitals as just a place to go get care, but you've got to keep those doors open, and that's what you're doing every day.
Yep, exactly. And again, the other balancing act that we have to do is the fact that we got employees that are working really hard. We don't want to lose them. So again, what do? We try to incentivize them in some way So at least we can continue to really deliver the proper care to the patients that we have. And unfortunately, it's all funding that's going to be needed.
That's how it works. And you're keeping those doors open and you're keeping that care flowing. And thank you for that. And thank you to your whole team for that. And again, thank you for joining us today. I appreciate you being here with us, Renee. And I think our audience thanks you as well. Thanks a lot.
All right. Thank you so much. I appreciate being here. Thanks.